Okey dah. Camera guna ni kan? Sekejap, tak guna yang ni. Dia guna yang tu.
Guna yang tu lah. Dia tu nanti dia dapat dagu sikit kan. Kita guna yang ni daripada depan Kita guna yang depan
Senang sikit. Dia tak kacau sangat. Okey, selamat pagi kepada semua. Nama saya Teo. Saya pegawai farmasi di sini. Ingin mengalu-alukan kedatangan semua anggota hospital ni ke sesi CME kita yang mingguan pada hari inilah. Untuk makluman semua, di sini ingin saya mengumumkan bahawa Jabatan Farmasi akan mengambil alih pengurusan CME Hospital bermula bulan Jun pada tahun ini. Dan ini merupakan sesi pertama yang dianjurkan oleh Jabatan Farmasi lah. Okey, untuk hari ini topik CME kita akan berkisar tentang impact of obesity on obstetric and gynaecological outcomes yang bakal disampaikan oleh Dr. Siti Ahmad, Ketua Jabatan ONG Hospital kita pada pagi ini. Untuk makluman semua juga, link kehadiran kita hanya akan dibekalkan pada akhir rancangan pada hari ini. So sila tunggu sehingga akhir pembentangan baru kita akan edarkan kehadiran. Terima kasih kepada semua. Tanpa melengahkan masa, tuan-tuan dan puan-puan, di sini ingin saya jemput Dr. Siti Ahmad untuk menyampaikan ceramahnya yang bertajuk Impact of Obesity, Impact of Gynaecological and Obstetric Outcome. Dipersilakan.
Okey, Assalamualaikum dan selamat pagi semua. Untuk CME pada hari ini saya akan membentangkan tajuk berkaitan dengan impact on obesity on gynecological and obstetric outcome. Ini adalah outline of presentation. Saya akan bercakap mengenai definisi obesity dan classification of obesity. Kemudian saya akan beralih kepada epidemiology of obesity, termasuk di worldwide, di dalam Malaysia dan juga among pregnant lady, and after that I will proceed to what are the gynecological health issue that occur among obese women, and then followed by obstetric related health issue include during antenatal, intrapartum and also postpartum. And lastly, I will go on the management of obesity in general. So this is the introduction. As we know, obesity is considered by WHO as a disease. And what are the definition of obesity? So obesity is a condition of which excess body fat to a degree where it can cause impairment to the health of an individual. So as we know, obesity is increasing worldwide in both rich and poor country. So how do you classify obesity and also overweight? So by using body mass index. So saya rasa semua orang tahu kot how to calculate body mass index, in which we use person weight in kilogram divided by square of his or her height in meters. And then overweight is defined when BMI is greater or equal to 25, and obesity is when BMI is greater than or equal to 30. So obesity can be further divided into three categories, in which class 1 obesity, the BMI is between 30 to 34.9. And then class 2 obesity, when the BMI is between 35 to 39.9. And class 3 or morbid obesity, when BMI is more than 40. Tapi WHO has classified the other specific BMI classification for Asian population, in which for Asian population kita define as overweight when BMI is more than 23. Maksudnya rendah lah berbanding dengan yang WHO worldwide tu. And then obese class 1 when BMI is more than 25 to 29.9, and obese class 2 when BMI is more than 30. So this is the table compare between worldwide BMI classification by WHO, and this is also by WHO but specific to Asian population. So why WHO come out with this classification for Asian population? Because there are the evidence from several Asian countries yang showed that risk for comorbidities in Asian population begin to rise at lower BMI value. And then they compare Asian with Caucasian to European population yang ada similar same BMI, but then bila dia compare, noted that among Asian population the body fat is higher percentage. Maksudnya dia ada lebih banyak body fat kalau compare dengan Caucasian and also European population. Tapi dalam clinical practice kita tak guna yang WHO Asian punya Asian population lah. We use the worldwide BMI classification from WHO. Then we move on into epidemiology of obesity. So based on WHO, tahun 2016, more than 1.9 billion adult aged more than 18 years old overweight, and more than 650 million adult were obese, in which 39% overweight and 13% of world adult population were obese in 2016. And more common in women, in which 40% of women were overweight and 15% of women were obese. And when it compared to the between 1975 in year 1975 and 2016, the prevalence of obesity triple. Maksudnya naik lah kan. So how about in Malaysia? Based on National Health and Mobility Survey in 2019, saya punya ni it found out that during from the survey, 1 in 2 adult population in Malaysia were obese, and it was found to be highest among females, and most common in Indian ethnicity, which comprise 63.9%, and more common in age of 55 to 59 years old. And from this survey, it is found out that 1 in 2 adult in Malaysia had abdominal obesity. So apa itu abdominal obesity? Abdominal obesity is when the waist circumference more than 90 cm for men and more than 80 cm for women. So this is found to be highest among female, more in Indian ethnicity, and age group to 60 to 64 years old age group. So how about the prevalence among women of childbearing age? This is from data from American College of Obstetric and Gynaecology. It stated that the prevalence of obesity among a childbearing age account for 31.8% to 58.5%. And from Society of Obstetric Gynecology in Canada, it stated that the prevalence of obesity in women of childbearing age is 11 to 21%. So how about the prevalence of obesity in pregnancy? In Australia and New Zealand, it stated that 50% of pregnant lady were obese. And based on UK punya data, the prevalence of obesity in pregnancy is account for 16 to 19%, and from Canada punya data is 10.2%. Tapi saya tak ada data untuk among pregnant lady in Malaysia. Tapi we have one data in Hong Kong based on old study done in year 1995 and 2005. It showed that 15.8% women are overweight at her first visit during booking. Tapi kalau kita guna yang WHO yang Asian punya population, the prevalence akan increase daripada 15.8% kepada 31.7%. So now we move on into what are the gynecological related health issue that can occur among obese patient. So first of all, the issue is for puberty. So in a young childhood, if in a young girl who is obese, they will be associated with early onset of puberty. Usually, normal age for puberty in young girl is around 10 to 11 years old. However, in childhood obesity, they will attain puberty maybe as early as 8 years old. Or they can have their menstruation once their body weight is 48 kilogram or 17% of body fat. Why? This is because because of the adipose tissue, it increase the bioavailability of sex steroid hormone. Then it promotes early adrenarche, puberty, and telarche. So uh, the a girl with early onset of puberty will have the increased risk of ovarian hyperandrogenism and also polycystic ovarian syndrome later in life. So when this girl get married, so the problem that she will face is infertility, in which obese women have to been shown to require a longer time to conceive. Why? This is because obesity is associated with increase in leptin, so causing the stimulatory effect on the hypothalamo-pituitary ovarian axis, and then it inhibit ovarian folliculogenesis and also LH, so causing an ovulation. Beside than that, obesity also related to hyperinsulinemia, so causing increase in androgen level, so cause hirsutism, menstrual disorder, and ovulation. And obesity also promotes peripheral conversion of androgen to estrogen in adipose tissue. Thus, it will inhibit GnRH secretion. So, kesimpulannya, obese women have higher risk untuk to have a problem in conceive in to get pregnant because of the an ovulation. Okay, when the obese woman seek treatment for fertility and they underwent the assisted reproductive technique, they also will have a problem in which obese women with ovulatory problem, they can respond poorly to ovulation induction. And then obese women who have insulin resistance, it also predict the treatment failure following the gonadotropin treatment. And obese women who underwent fertility treatment and assisted reproductive technique will associated with increase in gonadotropin dose usage, reduce in follicular production, increased risk of cycle cancellation, and have lower pregnancy rate. So conclusionnya, obese women yang underwent fertility treatment, they will have lower chances to get pregnant, even though they kita kata dia buat IVF kan, in vitro fertilization or intrauterine insemination, but then the pregnancy rate will be lower in obese women if compared to the lean woman. So how about the contraception? As we know, obese women associated with many complications during pregnancy, and over half of all maternal deaths reported in UK is occurred in women who are overweight or obese. So effective contraception is required. However, contraception use remain low in this group. Sebab apa? Sebab they perceive that obese women ni tak fertile. So, dia orang tak gunalah kaedah-kaedah perancang. And then because of the fear regarding the hormonal contraception related weight gain. However, there is little evidence to link significant weight gain either with combined oral contraceptive pill, levonorgestrel intrauterine system, and also progesterone only pill. Tapi usage of Depo-Provera shown to cause weight gain around 9 kilo over 5.5 years of usage. And then what are the other problem with contraception in obese women? Usually the efficacy of hormonal contraception in women will be in women with high BMI also will be reduced due to lower plasma concentration of active agent. So other than that, usage of combined oral contraceptive pill in obese women are also associated with risk of venous thrombosis by 10-fold in overweight women. Now I will go on to the specific benign gynecological problem that among obese women. First one is menstrual problem. So as we know, obesity it will associated with menstrual problem in which they will experience a long and irregular cycle. So women yang have BMI more than 35 have a 5-fold higher risk of long cycle. And BMI more than 30 and waist circumference more than 88 centimeter will have a risk of having irregular cycle. So as we know, 30 to 75% of women with PCOS is obese and it associated with menstrual irregularity. And then second problem is endometrial polyp. Endometrial polyp, why it occur among the obese women? Because the estrogen excess in obesity, it associated with pathogenesis of endometrial polyp. And most of endometrial polyp is benign and 1.5% are associated with malignancy. The third problem is uterine fibroid. So obesity had been linked with uterine fibroid. So in a retrospective study, it showed that women with fibroid is more likely to be obese or severely obese. Why? Because of obesity cause relative hyperestrogenic state, which encourage the fibroid growth. Other than that, women with higher BMI also has a risk of urinary incontinence. The study demonstrate a link between the BMI and also urinary incontinence. And women with increased waist circumference associated with stress urinary incontinence because of raised intra-abdominal pressure due to central obesity. Ni maksudnya yang abdominal obesity kan, when the waist circumference is more than 80 cm, so they tend to have higher risk to get stress urinary incontinence. And then the severity of urinary incontinence is influenced by duration of obesity. So kalau obese tu daripada muda-muda lagi, so the severity of urinary incontinence is more severe if we compare to women yang obese at late adulthood. And then the last problem is pelvic organ prolapse. The prevalence of pelvic floor dysfunction is highest among morbidly obese women if compared with obese women. And usually the symptoms of cystosis, rectosis and uterine prolapse will be worsened among women who were overweight or obese. So this is the table, simplified table for what I said before. What are the impact of obesity on the gynecology? And then we move into the obstetric related health issue that can occur among obese lady. So when they get pregnant, during early pregnancy, they tend to have higher risk of first trimester and also recurrent miscarriage and also fetal anomaly. There are number of studies demonstrate that risk of miscarriage is higher in overweight and obese women following spontaneous conception or following fertility treatment. Why? This is because the obesity impact on ovarian environment result in impact folliculogenesis and also oogenesis. And it also stated that increase the production of inflammatory and pro-thrombotic agent, which is plasminogen activator inhibitor, which associated with increased risk of miscarriage in association with maternal obesity. And then a woman who have pre-pregnancy obesity, maksudnya sebelum pregnant pun dah obese, when she get pregnant, she have twofold increase in risk of neurotube defect. And when the greater the maternal BMI, the higher risk baby to get congenital malformation. However, the mechanism to link the obesity and congenital anomaly is not fully understood. What are the problems that we face during managing the obese woman? So first of all is a limitation on the obstetric ultrasound. So masa nak scan obese woman, we have the limitation to detect any fetal anomaly. So the ultrasound will reduce the sensitivity. Obesity will reduce the sensitivity of ultrasound as a screening test for fetal anomaly. And scan that performed on women with BMI greater than 19 centile during second and third trimester will have reduction of 14.5% in visualization of organ compared to lean woman. Maksudnya kita tak boleh nak visualize all the organs compared to lean woman in obese woman. So what are the problem that during antenatal that can associated with obese woman? So first of all is hypertension or preeclampsia. As we know that hypertensive disorder are more prevalent in obese women than in their lean women. In women who have BMI more than 30, it is increased in the risk of preeclampsia by 2 to 3-fold. And in a systemic review of risk factor for preeclampsia, women with raised BMI compared to normal BMI associated with 50% of increased risk of preeclampsia. And in women who have booking BMI more than 35%, they are the double risk to get preeclampsia in later pregnancy. Problem number 2 is gestational diabetes mellitus. So as we know, maternal obesity is most common risk factor for GDM. And in a large cohort study, it is reporting that the increased risk of 3-fold for GDM in obese mother. So in obese mother with GDM, dietary advice, blood glucose monitoring, insulin initiation and good control of blood glucose will significantly reduce risk of bad perinatal outcome, include fetal macrosomia, shoulder dystocia and also perinatal death. Problem number 3 that can occur during antenatal and postnatal among obese women is venous thromboembolism. So obesity is associated with increased risk of VTE during antenatal and postnatal. And based on Royal College of Obstetric Gynaecology guideline, it stated that a woman who have BMI more than 30 plus other risk factor for thromboembolism will be considered to give prophylactic low molecular weight heparin antenatally and will continue the dose until 6 weeks postpartum. However, in women with BMI more than 40, regardless of mode of delivery, so should be advised to receive a minimum of 1 week low molecular weight heparin postnatally. And other than that, other measures to reduce the risk for venous thromboembolism in obese women is early mobilization, and then after surgery or delivery or usage of graduated compression stocking. Other than that, the problem that we face by obese women is perinatal complication. So what are the perinatal complication that related to maternal obesity? It include increased risk of stillbirth, prematurity, fetal macrosomia, increased risk of congenital abnormality, and also perinatal death. So what problem that obese woman will face during intrapartum? So in an obese woman who have previous cesarean section and she willing to trial of vaginal delivery, so the risk for her for successful vaginal delivery is lower if compared to lean woman. And then morbid obesity also carries a greater risk of uterine rupture during trial of labor. Beside than that, elective induction of labor at term may reduce the chances of cesarean birth without increasing risk of adverse outcome. However, spontaneous delivery is preferred in obese women. So from these two guidelines, obesity alone is not an indication for induction of labor. Other than that, obese women also associated with higher incidence of intrapartum complication include slow labor progression, operative vaginal delivery via vacuum or forceps delivery, shoulder dystocia, postpartum hemorrhage, and also emergency cesarean section. So cesarean section in obese women more technically difficult and it associated with more complication such as wound infection. And beside than that, obese mother also associated with higher risk from anesthetic complication, includes of failed epidural, increased aspiration during GA, and also difficulty with intubation. So what are the postpartum issue? Basically, because of delay in physiological lactogenesis due to alteration of adipose tissue mass in obesity, so it will affect the breastfeeding initiation and also can cause earlier cessation of breastfeeding. And then obese mother also associated with increase in anemia and also depression during postpartum period. Now I would like to talk on obesity and malignancy. So there is evidence that obesity is a risk factor for developing gynecological and also breast cancer. So in obese women with cancer, they have an adverse effect on survival due to late screening. So because of later screening, so delayed in diagnosis, and because of patient have an comorbid illness, and then poor response to the treatment, and also obese women usually increase in surgical and radiation complication. And there is also suboptimal treatment with chemotherapy, as obese patients are more likely to receive reduced dose of chemotherapy compared to normal weight women, as we worried about the overdose or when the obese women have coexisting systemic illness. So how about the relation of obese women with endometrial cancer? The combined risk ratio of developing endometrial cancer is increased in BMI above 27 kg per meter square. In a large cohort study, they stated that increased risk of endometrial cancer increased in higher BMI, and 40% are related to overweight and also obesity. So why obese women associated with endometrial cancer, carcinoma? This is because of unopposed estrogen that produced by adipose tissue. That adipose tissue convert the androstenedione to estrogen. So this is the source of unopposed estrogen to the endometrial cavity. And then for ovarian carcinoma, 30% increased risk of ovarian carcinoma in obese women. And the hypothesis is in menopausal women, adiposity enhance the ovarian cancer risk through the mitogenic effect of excess endogenous estrogen, which synthesized in the adipose tissue. So in ovarian carcinoma, obesity was positively associated with clear cell tumor rather than invasive endometrioid or mucinous tumor. And in cervical cancer, usually we have higher mortality noted among obese women. Why? Because they less likely to undergo cervical screening. Maksudnya obese woman ni dia tak buat pap smear. So bila tak buat pap smear, so late diagnosis. So bila late diagnosis, usually bila kita dah diagnose tu dah diagnose with late stage. So delay the diagnosis and they have higher mortality. And more common histopathology is adenocarcinoma if compared to squamous cell carcinoma. So I will move on the last part of the presentation, which is management. So this is general management. So the most important in managing obese women is lifestyle modification and also dietary intervention. So it's stated that in polycystic ovarian syndrome, when a woman loss of 5 to 10% of body weight, they will result in improvement in PCOS. So it can encourage spontaneous ovulation, and also patient can get pregnant spontaneously. Second line is pharmacological intervention. There are few medication which involve orlistat. This is inhibit pancreatic and other lipase. This inhibit fat absorption. Other than medication is sibutramine. It inhibit reuptake of serotonin and also norepinephrine, so resulting in increased satiety. However, it's not recommended in women who are planned for pregnancy. Third one is metformin. In randomized control trial, it concluded that treatment with metformin resulted in significant reduce in BMI if compared with placebo. And metformin alone or combination with clomiphene in PCOS patient akan increase ovulation rate and also clinical pregnancy. The third management is a surgical treatment which involve bariatric surgery. This is the last resort in women who are unresponsive to other intervention for weight loss. And this surgery will reduce calorie intake by modifying anatomy of gastrointestinal tract via restrictive, malabsorptive or combination. So following the bariatric surgery in morbidly obese women, it improve in fertility and it also reduce the risk of obstetric complication. However, in women who have bariatric surgery, pregnancy should be avoided 6 to 12 months post-surgery. So this is the recommendation for clinical management prior to and during the pregnancy. So women who are morbidly obese should receive the pre-pregnancy counselling. And we should consider to give them higher dose of folic acid 5 milligram because of they tend to have higher risk for congenital abnormality kan. And then a healthy diet and exercise are important in pregnancy, so we need to refer to dietitian and then advise them to avoid excessive weight gain. And when they get pregnant, so provide them an early booking visit and plan for pregnancy management. And in a obese woman who have other additional clinical risk factor for preeclampsia should prescribe a low dose of aspirin. And as they have higher risk to develop preeclampsia later in pregnancy. And then consider antenatal thromboprophylaxis if there are additional clinical risk factor, and recommended a detailed scan anomaly for congenital to detect any congenital abnormality. And then we need to consider MOGTT at 28 weeks because they have higher risk to get gestational diabetes mellitus, and may consider to refer to anesthetic team in patient with BMI more than 40 as they tend to have higher risk of anesthetic complication. With that, I end my presentation. Thank you.
Terima kasih kepada Dr. Siti Sarah atas pembincangan tadi. Okay, jangan keluar dulu sebab kita baru saja nak ambil kehadiran untuk semua. Kali ini kita akan ambil kehadiran secara pada akhir presentation untuk memastikan semua dapat menikmati persembahan terlebih dahulu lah. Okay, untuk semua sila kalau katakan gunakan komputer boleh scan QR code ni, ataupun kalau secara handset boleh copy link tersebut untuk isikan borang kehadiran untuk sesi CME pada hari ini. Pautannya akan ditinggalkan selama 5 minit untuk kita sebelum kita mengakhiri sesi pembincangan pada hari ini, dan kita serahkan lokasi ni kepada tim Lean Management Healthcare lepas ni. Sekali lagi diucapkan terima kasih kepada semua, dan kepada mereka yang terlepas pengumuman tadi sebelum presentation, kami ingin memaklumkan bahawa Jabatan Farmasi secara sahnya akan mengambil alihlah pengurusan CME Hospital Sultan Maleha untuk pertengahan kedua tahun ini bermula Jun sehingga Disember. Ada beberapa soalan tak untuk ditanyakan dalam YouTube chat kita? Yang tak boleh scan tu boleh type dalam kita punya YouTube chat tu, saya dah masukkan link tersebut. Semua boleh scan tak yang lain? Boleh kan? Ada yang cakap tak boleh scan. Terima kasih kepada semua. So, kita akan tamatkan pembincangan kita pada hari ini. Jumpa lagi pada masa yang sama minggu depan. Terima kasih.